So let's move on. Very good discussion, and I think it's interesting. There's 5 of us here with 7 different opinions on what to do after or how to interrogate post-osimertinib for mutations and what chemo to give, and I think it just highlights the competing standards that are, and we're just still trying to learn what to do. So let's move on. We've talked about osimertinib. There are other emerging TKIs that we've learned about in the past 6 to 12 months, specifically at ASCO this year, and then subsequently published in the JCO at the same time with the Archer data and the dacomitinib. And Shirish, you want to just walk us through that briefly?
Right. So I think the results of this study reflect how quickly the field is moving. I mean, here we have a trial where we have a survival improvement of comparing one TKI to the other, one of the first studies to demonstrate such a survival improvement in the field of thoracic oncology. And despite that, may not necessarily change the standard of care. So Archer 1050 was a study that was actually presented at ASCO last year for the first time, which randomized patients with EGFR mutation positive, the sensitive mutations, either exon 19 deletion or L858R exon 21 mutation, to either dacomitinib at its dose of 45 milligrams a day or gefitinib at 250 milligrams a day. And at last year's ASCO, what was demonstrated was that there was a significant improvement in progression-free survival, which was the primary endpoint with a hazard ratio of 0.59, and that translated into a median progression-free survival with dacomitinib of about 14.7 or approximately 15 months, and 9 months with gefitinib. So it was a pretty impressive improvement in progression-free survival. The 2 important things to note about this study is, one is that the study specifically excluded patients with brain metastases, and based on several series, that the percentage of patients who have brain metastases at baseline can vary from 25 to even 38%. So that's a substantial proportion of EGFR mutation positive patients that were not enrolled on this study. And the second issue is the toxicity. So patients can have both rash and particularly diarrhea that can lead both to a significant proportion of patients requiring a dose reduction from 45 to 30 milligrams and requiring drug discontinuation. But at this year's ASCO, the study demonstrated an improvement in overall survival, which was not the primary endpoint. Nonetheless, it was quite striking that there was a survival improvement in patients who received dacomitinib with a hazard ratio of 0.76. So there was a 24% reduction in the risk of dying in patients who received dacomitinib. Now, I do view this data with a little bit of caution when you look at medians, and clearly hazard ratios are more reflective of the benefit. But when you look at the medians, the median survival with dacomitinib was about 24 months. But the median survival with gefitinib was about 26 months, and that would be considered somewhat less than what we have seen in studies done in comparable time periods, where usually we have seen median survivals with the first generation EGFR inhibitors in the range of around 36 months or somewhere around 3 years. And so it raises the possibility that the standard arm underperformed. Nonetheless, to see a survival advantage was truly impressive. The reason I felt it may not necessarily change the standard of care is we now have osimertinib. If this data was presented 3 years ago, 4 years ago, I think one would have, despite the toxicities observed with this drug, incorporated the drug in the standard practice. But now that we have osimertinib, which has shown an even more impressive, yes, progression-free survival and not yet an overall survival advantage, I believe that this doesn't necessarily displace the osimertinib, but does raise the possibility, and this is pure speculation, that the FLAURA results may also land up with a longer follow-up, showing a survival advantage.
And let's not forget afatinib, LUX-Lung 3 and 6, which had 31 and 33-month overall survival. So this is not an unprecedented, shockingly impressive overall survival.
So I do think, at least for the United States, that dacomitinib is probably not going to have much of a place in the U.S. Mm-hmm. But I think throughout the rest of the world, dacomitinib will be utilized because of the difference in medicine, healthcare, costs, mm-hmm.
Mm-hmm.
And the fact that in Asia, dacomitinib is more commonly used, and osimertinib is not widely available.
Yeah. I agree. I think the toxicity of the drug, as Shirish highlighted, is probably going to be prohibitive, and its routine use in clinical practice here There were a large percentage of these patients who had to be discontinued from treatment on that trial. But let's give it credit. It is the first phase 3 trial comparing TKI versus TKI that did show an OS advantage. It will be interesting to see if there will be any traction of this in the U.S. I think, I agree with Ann, I think the traction will be globally, and with osimertinib landing front and center, given its efficacy and just how well tolerated that drug is, I have a hard time understanding where this drug is going to land here in the U.S.
And as we discussed when we were discussing osimertinib, the toxicity profile and the CNS activity. So not only are the numbers a little more impressive in FLAURA, but when you combine that with its activity in the CNS, which we don't have any evidence that dacomitinib necessarily have similar activity in the CNS because they excluded those patients, and the toxicity profile, I don't think that this would change the standard of care at the present time.